Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Our topic today is a search for the perfect hypnotic. Now, such a search goes back centuries. People have always wanted to find the perfect medicine that will give them a good night's sleep. As sleep specialists, I think we probably all agree that the best medicine for insomnia is cognitive behavioral therapy for insomnia. But you know, there are many patients who can't get access to this, who've tried it and found that it doesn't work and are still looking for medications. The best known drugs, of course, are the benzodiazepine agonists, the Z drugs, but they have definite side effects and are not particularly efficacious. To discuss alternative medications, my guest today is Dr. Bhanu Kolla, Professor of Psychiatry at the Mayo Clinic College of Medicine and Science, and a board-certified specialist in both sleep medicine and in addiction medicine, so really a perfect person to talk on this topic. So, Bhanu, thank you for speaking today. The latest kids on the block are the Orexin Antagonists. What are those? How do they work, and how effective are they?
Mike, first off, thanks for having me. It's a great pleasure being here. So, yes, we have been looking high and low for the perfect hypnotic, and I think the search continues. With that said, the latest class, so like you put it, the new kids on the block are what are called dual orexin receptor antagonists, or DORAs for short. So Orexin, also called hypocretin, but now mostly goes by just orexin, is a neuropeptide that was discovered towards the mid to late 90s, and we have come to know much more about it recently. So in the lateral hypothalamus, we have roughly about 50,000 neurons that secrete this particular chemical. It has a major role to play with sleep and wakefulness, but also a role in appetite and a few other homeostatic mechanisms that it controls. Initially, our understanding of the orexin compounds and receptors came through our study of narcolepsy. So what we found, especially in narcolepsy type 1, is that this particular compound is either very low or completely absent in the brain. And that is due to destruction of the neurons that produce this. So narcolepsy, we all know, leads to excessive sleepiness. There is this absence of orexin. People are excessively sleepy. There are also other symptoms such as sleep paralysis, hypnagogic, hypnopompic hallucinations, which play a role in the side effects with these medications. So it's good to sort of link those together. So once we found out that orexin is important in promoting wakefulness through various mechanisms, it very quickly became apparent that if we block orexin, maybe we can help put people to sleep. So this is quite different from all the previous medications that we have had, which included barbiturates, initially benzodiazepines, the Z drugs, and some of the other medications that we use both on and off label, like Doxepin, trazodone, which work through the histaminergic system, where they're shutting down or working, most of them working through the GABA mechanism, and therefore promoting sleep or shutting down histaminergic system. But this mechanism of action for the orexin antagonists is novel. And the first drug that was approved was Suvorexant, but we have two others, at least in the US, that have FDA approval now, Lemborexant, and the latest one, daridorexant.
So how effective are they? What have the trials shown? Are they miracle drugs?
The They are effective. I don't think that I would call them miracle drugs. They are different. That's the other thing to keep in mind. So there have been multiple trials, randomized control trials, and that's how they have gained regulatory approval. With Suvorexant, it is currently approved at doses of 10 to 20 milligrams. And this again is a little interesting in that the initial efficacy trials were done at higher doses. So the FDA actually approved dosages a little lower than what the initial trials were performed on because of some concerns about safety. And Lemborexant and daridorexant have also been extensively studied with over 1,000 patients in randomized controlled trials in with both of these drugs. And yes, so they do help improve how quickly people fall asleep, how much sleep they get, and also more importantly, their perception of their sleep as to improved quality and also better daytime functioning. The question then is, are they better? There have been little to no head-to-head comparisons with previous medications. So they're different, they're effective, but I think the question as to whether they're better still remains to be answered.
And what about safer? There was a sub-study later of Suvorexant looking just at the older patients and seemed to indicate that there was no difference between drug and placebo on motor vehicle accidents and falls during the night, which has led some people who work in geriatrics to think maybe these are safer drugs for older people compared to the Z drugs. Is that true? Is this something we should be considering?
So first off, I'd like to start with talking a little bit about the side effect profile, and we will get to the efficacy in the elderly. So the main side effect with any hypnotic is that it causes sedation, and that sedation, if it lingers during the daytime, can cause some daytime grogginess. So really want to avoid that. That comes down to also the half-life of these medications. Suvorexant seems to have a half-life of roughly about 12 hours. Lemborexant is longer, acting about 17 hours, and daridorexant, the newer drug, roughly about 8 hours. With that said, though, overall, the concern for daytime sedation is quite minimal with all of these drugs. The other side effects could include nasopharyngeal congestion, headaches. Those seem to be the common ones. There is a concern because all of these are orexin antagonists that they can cause, and there have been some reports they can cause sleep paralysis, some hallucinations while people are about to go to sleep, about to wake up, and concerningly, but quite rarely, suicidal ideation. So those are things that people need to watch for with these medications. Again, with the serious side effects, extremely rare, but something to just keep in mind. Both Suvorexant and more recently daridorexant have been specifically studied in the elderly population, so 65 and older, and have been found to be relatively safe. So at least we have randomized controlled trials in older subjects showing that the side effect profile is relatively benign. Again, these are not head-to-head comparisons with the older drugs. With benzodiazepines especially, I think that the evidence is reasonably clear that they can increase the risk of balance issues, falls, and with falls, increased risk of fractures. With Z drugs, that particular line of evidence is still a little unclear, with the confounding being that insomnia also causes falls at nighttime, so people are likely to be up and about, therefore fall. The cognitive issues too, I would say, currently are unresolved, with studies showing insomnia itself being a risk factor for cognitive impairment. And some more recent studies, especially Danish studies, showing that there probably isn't that much cognitive impairment, at least long-term, with the Z drugs. That said, there are increased risks with these particular drugs, the benzodiazepines and Z drugs, of anterograde amnesia, complex behaviors such as driving, doing other things. And at this point, we do not have reports of those happening with the DORAs, but we also need to know that these are relatively new drugs. So less likely, but we don't know for sure, is how I'd put it.
Good. Well, that's very helpful. Let's talk about a couple of other options. Antidepressants. Now, Doxepin is the one in low dose, or the old tricyclic Doxepin in 3 to 6 milligrams. It's approved by the FDA for insomnia, but off-label, trazodone has been used widely over the years. Even mirtazapine has been used. Are these appropriate?
So Doxepin has an interesting story. So as you said, for decades now, we have used it as an antidepressant, but usually that's at doses of 100 milligrams roughly. And at that point, it is pretty much a tricyclic. So it's affecting the serotonergic, noradrenergic systems, has quite significant anticholinergic properties. The trials with low-dose Doxepin have involved 3 and 6 milligrams, and we think from a pharmacological standpoint, at those doses, it is working almost exclusively as an antihistaminergic drug. It's been found to be safe, it's been found to be effective, but it is brand name. The lowest dosage of the generic version as a tablet is as a capsule is 10 milligrams. It is available as a liquid, and you can, through some creative dosing, get to the 3 and 6 milligrams. So just so people are aware that the generic version is available, it's quite safe and has an FDA indication. Trazodone is an interesting drug. So as in my introduction, you talked about how I'm boarded both in addiction psychiatry and sleep medicine. Psychiatrists love trazodone. We've used it for decades. We think it's quite safe. We think it's effective. We believe that the abuse potential is much less compared to the Z drugs and the benzodiazepines. So I call it the drug that refuses to die. It keeps getting used. And there have been some recent trials where trazodone has been used as the control arm in certain more recent Z drug trials and also CBTI trials, where it's been shown to be relatively effective. The AASM has a weak but against position against trazodone because of concerns of daytime grogginess. And I think we need to see that in the context of some of these other advantages that I talked about, which is we have decades of clinical experience, we think that it has low abuse potential, and people are just more comfortable with it. We use it between 50 to 150 milligrams. After 150 milligrams, the sedating effects tend to sort of plateau and we don't get any more purchase. So it's usually not worthwhile going beyond that. Daytime sedation can be a problem. It can cause orthostasis. A rare but serious side effect is priapism. So that's something you need to warn your patients about. They need to get to the ED if that happens. The other medication, mirtazapine, again, an antidepressant, has a very specific mechanism of action, but is quite sedating. It starts working as an antidepressant at doses of 15 milligrams and over. Sometimes it gets used low dose at 7.5 milligrams for sleep, especially in psychiatric settings. And I think in the short term, that is relatively okay. Mirtazapine does cause an increase in appetite and weight gain. So over the long term, people really need to be watchful about how much weight their patients are gaining. With mirtazapine, it also has a specific mechanism of action wherein once you're at 30 milligrams and over, it tends to be actually less sedating. So as you get to higher doses, the sedation tends to go down. So again, something to keep in mind when you're prescribing it. In my practice, I almost exclusively use mirtazapine in my patients with major depression who are also having problems with sleep, where I can get both effects with one drug rather than use it as a pure hypnotic.
Oh, that's very helpful. So you mentioned that the effect of Doxepin is probably antihistaminic. So let's talk about over-the-counter antihistamines, widely used. Now, I had a patient this morning in his 60s who's been using 50 milligrams antihistamine over-the-counter for 20 years, gets excellent sleep. When he stops using it, his sleep deteriorates. His internist was very concerned that he's been using it for so long, can't we get him off it? No side effects that I could determine. Does it work? Is it safe in older people? What's your thoughts about over-the-counter antihistamines?
So Benadryl, diphenhydramine, tends to get used quite often. Doxylamine is the other over-the-counter antihistamine. We'll talk first about diphenhydramine, which a lot of people have ready access to, and along with melatonin, it's one of the most commonly used over-the-counter medication. The concern, especially in the elderly, is again, its anticholinergic properties, so urinary retention. It is long-acting, so can cause some daytime grogginess. There is a concern, again, because of the anticholinergic properties, it could be causing some cognitive impairment. All of these are potential risks. With every patient, you weigh the risks versus benefits. The overall risk, I think, is there, but is quite low. And in a patient who has tolerated it well, has tried to go off of it, is not experiencing any of those side effects, what I would counsel is careful discussion, risk versus benefit analysis. And I have a fair number of patients after that discussion opt to remain on the medication, which I think is perfectly reasonable. With
Well, that's good to hear, because that's basically what I said this morning to the patient.
Yes, well, we both subscribe to the same school.
Let's just briefly talk about melatonin. Now, melatonin, the physiologic dose, not dose, the physiologic level of melatonin produced in the pineal, I believe, is about 0.5 milligrams. We're seeing it used in massive doses for sleep these days. Last week, I had someone on 20 milligrams of melatonin. I've had people who've come in on 50 milligrams melatonin. Does it even work as a hypnotic? And what sort of doses, if so?
So melatonin, again, is interesting in that it is over the counter. The FDA does not regulate it, at least in the US, because it's considered a supplement, and that has certain implications that I'll get to in a little bit. It has been studied as a hypnotic and has some evidence supporting its use in doses of 3, 5, and up to 10 milligrams. Once we get beyond 10 milligrams, we really don't have much safety data. And that's what I tell my patients, that we think it's very safe up until 10 milligrams. Beyond that, we don't know if it is safe. And I don't think that it is much more sedating at doses higher than 10 milligrams as compared to just using the 10 milligrams. The evidence has gone back and forth in terms of whether it is more effective than placebo or not. And I think the current line of evidence seems to suggest that it is maybe not any more effective than placebo in increasing total amount of sleep or how quickly people fall asleep, at least as a drug for insomnia. It has its role in circadian rhythm disturbances, and that's a completely different story. With the caveat being that if it's no better than placebo, it is still having some effect. So it is helping, at least people think that they're falling asleep. It's keeping them asleep, and it's not causing any side effects. So if we have patients who have gravitated to it, are using it, are getting good effect, are under 10 milligrams in dosage, I just have them continue on it. And I have at times also prescribed it where it helps me get to know the patient. If they're working on CBTI, they're doing other things, or I wanted to delay prescribing something else, I think melatonin still has a role in sleep medicine.
Good, thank you. Of course, it also is used for REM sleep behavior disorder, but that's a whole entirely different topic. Well, we're somewhat running out of time, but I wanted to ask you one more question. Quetiapine. We're seeing that now prescribed to patients who don't have any psychosis or dementia, just as a sleep aid. Give us your thoughts.
Well, this is easy. I'm against it. Quetiapine is a very effective antipsychotic in patients who have schizophrenia. We use quetiapine as an augmenting agent in treatment-resistant depression, but it does cause weight gain. And there have been studies at low doses where it's been used just as a hypnotic. And there too, it causes not just weight gain, but significant dyslipidemia. So I don't think that those risks are really worth it when we have many other options available to us.
Well, I'm so pleased to hear you say that, because that's what I've taught. Never use as a simple hypnotic in somebody who doesn't have another indication. Bhanu, thank you so much. You've got a wealth of information and experience there, and I hope this has been helpful to our listeners.
Thanks so much, Mike. Absolute pleasure.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.